and a university professor and director of the Center for Global Health Research at the University of Toronto. So together, they will present their project and their research on using national polling data of household deaths to estimate excess deaths during COVID viral waves in India. So Yash and Prabhat, the floor is yours.
Great. We had planned. Thank you, Stefan. We planned for me to go first, but since Yash is already on the screen, Yash, why don't you go ahead and I'll follow you.
All right. How many minutes should I take? I mean, just for 3 minutes, 4 minutes?
Up to you.
So hi everyone. Me and Prabhat and with some other colleagues, we did a paper, as you know, on basically understanding the actual number of mortality rates in India, which were obviously way higher than the official numbers that were being presented everywhere. And there are reasons to that, basically the capacity issues. But I just here want to focus on my part, that is the data collection and how we do it in India. And just to give you an understanding of the demographics in India and how the surveys are carried out. India is basically a study of contrast. I will go very briefly and quickly. It's a land of 1.4 billion people. 1/6 of humanity lives in India. 1/3 of the world's chronically malnutrition children. They are in India. Almost every third male and every second female is practically illiterate. More than 300 million still sleep, just meal a day. And in the COVID, actually that much population dependent on the government food program to start with. But if you look into the other side of India, it's the biggest democracy with 900 million voters. 6% growth rate plus for 10 years, actually 4% is a recession for us. So that's the kind of economy that we are talking about. One of the 5 countries with GSLV technology, 4th country to land on the Mars, back office, nuclear powerhouse. And that is where you get the contrast of the country we are trying to map. We have 20 official languages, more than 100 major and 2,000 minor dialects. Majority of the major dialects stand as a standalone language in themselves. 28 states and 7 religions, 500 major and 3,000 minor social caste group, mind-boggling demographic diversity. The idea to give you all these numbers is to basically drive home one point, that India from every parameter is, in short, a nightmare for survey research professionals. In India, the Seawater covers, we do a CATI, RDD-based CATI, which we've been running for more than 10 years. We do interview in 11 languages. And it's the only survey instrument which has been running for every week for the last 10 years. And actually, since 1st of January 2019, we are running it on a daily basis, all 365 days a year. So when the COVID happened, actually, and this is the idea actually to give you the coverage of the CATI RDD omnibus in one typical week, the kind of geographic coverage. Each dot interview represents one interview, differentiates, actually represent different provinces and languages as well. So the coverage that CATI gives is awesome, and I will just explain how it is done and how it is carried out. The standard operating process in the routine CATI operation is just like any RDD process CATI operations that in the West or in any other country you have been looking like. No big deal in that. Basically, the computer generates a random number, the dialer puts them, randomly puts them across to the researchers sitting in the call center and, and conducting interviews. The only difference is that we have been interviewing in multiple languages. So each universe is taken separately for that purpose in terms of language or the state, and they are connected to that particular language researcher. However, the difference when after the COVID lockdown happened, the difference over here was that we had to do the RDD process in 2 split ways. One RDD was done on VIP connecting the basically the respondents, And another calling operation with the connection to researchers sitting in home actually, and then patching them through a virtual PBX system. So when the lockdown happened, we were already prepared for this setup almost 2 weeks before the lockdown happened. Luckily, we were trying to do it. We were just trying to be ready. And when it happened, we just happened to be the only survey operation process in running, not just in India, but basically in entire South and Southeast Asia, actually. We later realized that. And that allowed us not only to continue our routine omnibus operation, but it also allowed us to actually start doing questions, asking questions which were directly related to COVID. Did it have this entire decentralization process had its own impact on the output as well? The efficiency slightly went down because obviously when researchers are sitting in the call center, the kind of bandwidth that we managed to get at our office is not exactly the same bandwidth, the data bandwidth and other things that are available in their homes. So that is where some infrastructural, due to semi-automation and infrastructural issues, the output went down by 30% in terms of operation perspective. But nevertheless, something was better than nothing. The process continued, and that was critical for us. Okay, I will come down to this point in the last actually, but I would like to actually focus on when I was discussing this issue in WEPOR and other conferences everywhere. Many people did ask, why not do the online research? What's the problem with that? In the third world countries and in India, definitely the online is not useful because as you can see that we have got more than 90% teledensity, and actually it's more than 100% if you are talking about adults. The CATI works because its mobile phone is with everyone. Data is the cheapest. Mobile telephony is free. Actually, incoming is free. That's a big difference between what the CATI operation in the West and in these parts of the world are differentiated. Where actually we are the calling party pays system, where if we are calling on your mobile number, we pay for the call, not the respondent pays for the call as in the West. So that's a big difference. Yet, availability of data does not actually mean digital literacy. People can talk on the smartphone, watch on the phone, listen on it, but does not automatically mean that they can also read or write on the smartphones. This is why CATI actually works way better in the third world countries. We actually jumped the landline telephony generation and directly landed on mobile, and we actually skipped the entire computer generation and we directly landed on the smartphones. When we say we, it's not just India. Please remember, I'm talking about majority of the upcoming, societies, upcoming economies in the entire southern hemisphere. This is true for majority of the countries because we worked in many other countries as well. So we know it works in the same way. The CATI works, the online doesn't really work simply because half the population actually cannot read and reply your questions online. So it has a very, very high income, high education, urban bias as far as the online samples are concerned. While in the case of CATI, everybody knows to talk, everybody loves to talk. And India being a contextual society, we do a absolutely gem of a response rate when compared to, our work in the West, with really pathetic response rate that everybody has almost stopped calling on landline and even into the mobile phones. This is different. So what are we tracking in the Corona Tracker? You can go to the website actually, apart from the main symptoms, and this has been, we have been carrying out. And when I had my first discussion with Professor Jha, we were actually mapping not just the symptoms within the family, but also symptoms and that's around in the surrounding, which is in a larger extended neighborhood and everything. And this is why sometimes people said that, this data might not be exactly of the same household as you are asking for the surroundings as well. So in the follow-up survey, so we actually in COVID tracker, we actually interviewed more than 100,000 households across India in the 2 years period. So when we had to do the mortality tracking, a much in-depth survey for mortality mapping, we actually picked up about 10% of those panel members, I mean those who we interviewed in 2 years, and we called them back. And while calling them back, apart from the questions which are on the left, the warm-up questions, we directly asked the death of immediate household members living in that family, how many deaths have happened in the last 3 years. We started with 2019 because we wanted to have a baseline of the normal year, non-COVID year, and then we asked for each death, the gender of the death, the person who has died, the age, which month and year did the person die, and if there was a diagnosis available, and if they were hospitalized, if yes, how many days, and if hospitalized, then was the person in ICU or ventilator or given oxygen, and was that available? And then we went into much more detail of the diagnostics, because that's where we wanted to understand how people are telling, stating why the person died. And this could be the initial phase of verbal autopsy, because we have the verbatim details of people telling how exactly the person died. If required, probably with Professor Jha, we are now planning to do another follow-up on getting the proper verbal autopsy done with the two medical professionals in action, and looking into the details of precisely. But these first top of the mind recall details are very much available within the same mortality survey on mapping actually why the person died, and the details if the household members or the family members had those details with them. And then finally, we mapped about the remaining household members, those who are still living in the household, have been living, and other details of the household members, and if they also got infected with COVID, and if they got the COVID vaccine yet. If yes, which particular vaccine? If not, do they intend to get vaccinated? If not, what is the reason they do not intend to get vaccinated? And by the way, this is the data which actually right from the starting on the vaccination we have been tracking in India. This is the data which actually told very clearly that there is literally zero vaccine hesitancy as far as India is concerned. People were more than willing to get vaccinated, and right now, as per the government data, more than 98% have at least got one shot of vaccine for sure, and more than 2/3 of the adults have already got 2 shots of the vaccine. So till this point, we have covered all these things so far. But yes, as I mentioned in the previous slide on the verbal autopsy part, this part probably we also have that in recording in the verbatims. So we are looking into the probability of going into the next stage of verbal autopsy and look into the reasons, and going beyond corona, go beyond COVID, and looking into the comorbidities which were associated with the fact. So this is my part of the stuff. Rest, Prabhat, you can carry from here, probably.
Okay, let me just get my slides shared. I have to do some settings, I'm afraid. Okay, can you see my slides? Or not yet?
I can see that.
Okay, good. Let me then go ahead and start. I'm sorry, just doing the bit of delay trying to get my slides now. Okay, let me turn my slides. Great. Let me build up on what Yashwant has already covered about the C voter design. So I'll quickly show you the overall results of the C voter tracker along with others. And here's the conclusions of our work, which is published in Science in January of this year. So first, in 2020, in the first viral wave, there was widespread transmission, but mostly asymptomatic with lower than expected death rates, and much of the deaths were confined to urban areas. In the second viral wave, which was in March, April, May, June of 2021, there was quite a large excess of deaths. So basically death rates doubled during that time. And you put these together, and looking at India's national total of about 10 million deaths routinely per year, then these suggest that combined both viral waves caused something like a 30% excess, or between 2.7 to 3.4 million excess deaths, about 7 to 8 times the official death rates. So the Indian COVID patterns, as you have seen, have been characterized really by two large waves. The first one was approximately September, October of 2020, but then receded quite notably, and then a much larger wave of cases in April, May, June. So the first wave was probably the original Wuhan strain. Since WHO hasn't properly named the original Wuhan, I'm going to call it the Aleph strain, which precedes alpha in the Greek symbols. So this is alpha. This is mostly delta variant, and you see the deaths were notable here under the first wave, but particularly higher in the second. So what the main consequences, I think, that we see is what happens if you have uncontrolled transmission in a population. And this lesson is quite important. It's actually being seen now to some extent even in Hong Kong or in parts of China or East Asia. A large uncontrolled population infection can lead to substantial numbers of deaths. Now, the starting point in India, of course, is that of the 10 million deaths that occur a year, only 7 million are registered, and only 1.3 million of those have a properly completed medically certified cause of death. And this varies greatly by state. So the poorer states in the north, Uttar Pradesh, Bihar, Madhya Pradesh, have particularly large numbers of uncounted populations. It also is greater among females than males. So what were the conclusions of our studies? Well, first, COVID was the main contributor to the excess peak. As mentioned, the actual total was about 3 million, and the overall death rates in India are thus aligned with those seen in Latin American countries or similar countries. And they're similar also to external estimates that have been made. So C voter design, Yash has just explained. We tried to get as wide a coverage as possible. And here's the key results from out of C voters. So what you see here is on the y-axis, the percentage of households that reported a death, and that's shown in the red. And then in the blue are the daily counts of confirmed COVID deaths as reported by the government of India. And the dotted line represents the approximate number of deaths that would occur in a household based upon the earlier million death study data, daily variation that is recorded. So there is daily variation or weekly variation across the years. So we mapped the overall proportions. And the key thing to see here is that you see an excess, again, September, October, of about 1%, but still that's well short of the overall mortality that is expected, as about 3% of houses should report a death in that particular time period. And then this peaked, or this came down quite notably to close to 0 in February 2021. but then you see this extraordinary increase such that for much of May and June, going into July, the percentage of houses that reported a COVID death was greater than the expected all-cause mortality. If you take the average of this time period, it was significantly greater than what we expect for all-cause mortality. Now, as Yash mentioned, a weakness of the survey design is that it asks, although the first question asked about events in the household, the subsequent question asked about deaths in the household or surroundings. So there is a bit of lack of specificity. So the sub-survey asked more directly, just in the immediate household, very simply, who was alive in January 2019, who died, and when. And in fact, this is the question we're proposing be added to the Indian census, but asking who was alive in January 2020, who died since, and when. So in 2019, the mortality rates in that population were 7, and that's pretty close to the UN and the sample registration system rates around 8, or the SRS rates are lower. I believe the UN rates, so this is closer to the 8. Then by 220, they'd gone up modestly, but by 221, you see the overall death rates had increased substantially. And when we look at the patterns and see if houses reported COVID deaths or non-COVID deaths, according to their understanding, you see that in 2020, there was this paradox that in fact non-COVID deaths were greater than COVID deaths. But in 2020, COVID deaths, shown in the orange, were far greater than COVID or non-COVID deaths. What this suggests to us is that the classification by houses between COVID and non-COVID is somewhat arbitrary, that the big excess in deaths is occurring from many conditions. And as we know that, it's not just respiratory disease, but heart attacks and other things that can cause death. So overall, we found about 4.5% of houses reported COVID death versus 3.5% expected from all causes. That's in the main C voter study. And this sub-study shows very consistent temporal and overall patterns, including roughly a doubling of the overall death rates for 3 months. Now, how does this compare to other data sources? Well, if it's roughly a 30% excess, then what about other sources? Well, first resource we looked at was the Government of India's own reporting in approximately 200,000 health facilities nationally. And much of this is in rural areas, but this showed in 2021 a big excess of deaths in hospital, despite admissions actually coming down, and a smaller excess versus the earlier years in 2020. And when we look at this by urban and rural, what you see is in 2020, the excess was seen just in urban areas, not so much in rural areas. But by 2021, you see the excess both in rural areas and in also in urban areas. So the pandemic very much moved from rural to urban, or urban to rural in that time frame. So this is to recap all of the evidence. So this is the C voter-based national polling results, about 30% excess mortality, the facility-based 27%. And then we took several states that had good quality civil registration death reporting over at least a 10-month period. And conservatively, that comes up to about 26%. So there's a striking consistency between these estimates, and as mentioned, also a consistency with external estimates, including modeling-based estimates. And the World Health Organization's forthcoming estimates are very consistent with what we've estimated. So big question is what happened, particularly with that second wave. So we're doing some further work, as yet unpublished, in looking in Mumbai, which was very much a bellwether for the whole country. And what you see here is in the different waves. Aleph is the first wave, which I've renamed. WHO doesn't have this nomenclature, but it probably should adopt it. then the Delta wave and Omicron, which is the more recent wave. So what you see here is the cases in Mumbai were obviously highest for Omicron, intermediate for Delta, and then for Aleph. But interestingly, the death rate in the different waves was actually highest for the Aleph, followed by Delta, and then far lower for Omicron. And much of the deaths was concentrated in older ages, as shown here. So surprisingly, the Delta wave, the killer wave, had lower death rates, but the numbers of infections were so much higher that it was that combination led to the overall high death rates. Some other work that we're doing looking at testing, PCR testing in India, also shows an interesting pattern. This is a bit of a busy slide, so what I would ask you to do is just pay attention to the orange, which is the registered deaths in Mumbai, and the red line. And the red line represents the PCR CT values, which is the cycle threshold. And the way to think about this is a measure of viral load. So the lower the value, the higher the viral load. So what you see here is this is a measure of viral load. The viral load for the Delta wave started to rise in the tested populations as early as February or late February, and rose very quickly and sharply, and then was preceded by this giant wave of deaths. In contrast, you see the viral load for Omicron rose, but somewhat unevenly, and has plummeted very quickly. So we think what went on with why was this wave so much of a killer? Well, it was a combination of not necessarily higher lethality, but much widespread infection and a very high community viral load, meaning that those that had infected were obviously infecting others. And the higher viral load will very much relate to poor clinical outcomes. So to conclude again, COVID was the main contributor to the excess mortality. The Indian death rates are probably underestimated officially by 7 to 8 times. And overall, the COVID death rates in India are close to what we see in Latin America. I'm happy to take any questions. Let me stop sharing. Okay. Over to you, Stefan.
Stefan, are you there?
Yep.
Yeah, I'm
Okay.
back. So thank you, thank you, Prabhat, and thank you, Yash, for this great presentation. I think what we'll do is we'll save the questions for the end and do a Q&A at the end. And what I would like to propose is that we move to the next presentation. So by Bruno Lanquande from the Institut Supérieur des Sciences de la Population in Ouagadougou, Burkina Faso. And so Bruno is a demographer who obtained his PhD. Who obtained his PhD from the University Catholique de Louvain in Belgium. And he works on social inequalities in health and mortality, the evaluation of health programs, and the testing of innovative strategies of data collection on health in sub-Saharan Africa. And today he's going to present on rapid mortality mobile phone surveys, or RAMPS, during COVID-19, insights from Burkina Faso. So Bruno, the floor is yours.
Okay, thanks a lot for this presentation. And so the idea is to share with you an insight for the high frequency survey in Burkina Faso that we are doing in collaboration with the National Institute of Statistics. Next slide, please. So the objective of this project is to estimate excess mortality during COVID-19 in 5 lower middle income countries using mobile phone using mobile phone. So you know that this is really important in context where CRVs are not well functioning, and also during this pandemic. And it's also important in countries like Burkina Faso, where some regions are not accessible because of terrorist attacks. So it's not possible to conduct face-to-face interview. So this project comes as an opportunity to estimate excess mortality, also in general to estimate mortality in lower middle income countries. So the project is conducted in 5 countries: Burkina Faso, DRC, Malawi, Mozambique, and Bangladesh. And as specific objective, we intend to develop and validate the project instrument to generate mortality estimate by age, sex, and locality, and also to conduct some validation studies. It is important to mention that it's true that the project has a novel objective, but there are some specific objectives by site, so that sampling approach that are used and also the different questionnaires are not quite identical from one side to other sides. Next slide, please. Next slide. Okay. So here I will focus on the case of Burkina Faso, because what is going on in the other sides, in the different sides, are not quite identical. So I will share some insight for the case of Burkina Faso. So in order to validate the strategy we use here to estimate mortality with mobile phone surveys, we are going to conduct some validation studies. So the first step will be to conduct the validation studies with secondary data sources. And for the case of Burkina Faso, we rely on DHS that was conducted in 2021 and the 2019 census. So the idea will be to compare aggregate mortality estimate between the NAMS, the DHS, and the census. And for the census, we can try to conduct individual level analysis to compare in order to study error on ages and also to study death reporting. This is the first step that we will undertake to validate the NAMS strategy. And the second step to conduct a validation study in the Ouagadougou HDSS that follow up to 90,000 individuals since 2009. So the idea will be then to re-administer the NAMS module to individuals living within the HDSS and then to compare the reporting of death with routine with the reporting in the routine data collection in the HDSS. So in addition to individual level analysis, we'll also conduct aggregate level analysis just by comparing NAMS estimate with the HDSS estimates. So these are the two strategies we would like to use to validate the NAMS methodology. Next slide, please. So it's important to mention that the project is going on. So here I will just try to share with you some results that we have for the moment. So we start data collections, and so I can share with you some first results of the project. It's true that the final objective is to estimate excess mortality, but for the moment, what I can share with you is just some level of mortality and also call outcome. So for the call outcome, we can notice that it is really high. Response rate is really high okay. The call outcome are very high in the NAMS project, and I think that one of my slides was off, but it's not a problem. So the response rates are very high in the project, and we also noticed that at the beginning, we expected language issue, but right now we can see that with 2 languages speaking in the country, we can cover a lot of area sample. We succeed to interview a lot of people just by relying on 2 main languages that are spoken in the country. So these are really good news for us. Next slide, please. Now I'm presenting some estimate of under 5 mortality derived from the project. So here we are presenting estimate of mortality derived from truncated birth histories. So during the 7 years preceding the date of the survey among women of reproductive age. So we are comparing estimates derived from the RAMPS with estimate of the UN group on child mortality estimation, and also estimate derived from the 2010 DHS conducted in Burkina Faso and 2003 DHS. So here, we have a different graph, one for neonatal mortality, one for infant mortality, one for under 5 mortality, and differences by sex in under 5 mortality. What we can see is that estimates of neonatal mortality are consistent with UN estimate, and DHS estimate. It's also the same thing for under 5 mortality, but infant mortality that we derive from the RAMS tend to be lower compared to UN estimates. And also sex difference are a bit higher in the RAMS compared to DHS, to the DHS estimate. Okay, next slide, please. For adult mortality, all of you know that it's really difficult to find a good standard of adult mortality estimation. So here, the idea is just to compare UN estimate with RAMS estimate by sex. And what we can see it is that there are discrepancy between the 2 sources, with RAMS estimate tending to be lower for male and for female. And so this result raised a lot of questions. There is an overestimation in the UN or an underestimation in the RAMS. And the underestimation in the RAMS can come from underreporting of death, of displacement of event in times, because these estimates are related to the 3 years preceding the survey. And the underestimation can also come from an overreporting on surviving siblings in the RAMS. And so this is something that we have to investigate more in the RAMS in order to understand why there is a lot of differences between our estimate and UN estimate. Next slide, please. So overall, what we can say from our experience in mobile phone data collection in terms of mortality measurement in Burkina Faso, we can say that response rates are high in the RAMS, and also estimate of under 5 mortality are really encouraging. So you see that compared to UN estimate, we are really closer to UN estimate. But for adult mortality, we got some mixed results, and so we need to investigate more. And we also need for the moment, we didn't estimate all age mortality, but we will do it in the coming weeks. And the next step for this project is to continue data collection during 6 months, and also to conduct the different validation studies that will help us to validate the RAMS methodology, and to focus afterwards on the primary objective of the project is to estimate excess mortality and to share with the different partners the results that we have in this project. So is what I had to share, But I would like, I noticed that one of my slides was off. I would just like to say 1 minute something about the sampling design. So for the sampling design, in Vietnam, we use the random digit dialing as in other countries, and we also use phone numbers that were collected during a living standard survey conducted in Burkina Faso in 2018. So we are using two sampling design environments. It's all I had to share with you today. Thank you so much.
Great, thank you very much, Bruno, for this presentation. Much appreciated. And before we move to the next presentation, I would like to encourage the presenters to monitor the chat as there might be questions that are addressed to you. So Prabhat and Yash, there are some questions that pertain to your presentations. So I would like to encourage interactions through the chat as well. And of course, we'll try to get back to some of this during the Q&A later. Okay, so we are now moving to our third presentation, which will be on the survey evidence of excess mortality in Bihar in the second COVID-19 surge. So this presentation will be made by Apurva Bamzai from the University of Pennsylvania. Apurva is a researcher working in development research and the public policy space, and her interests are in social policy and economic research, quantitative analysis, and mixed methods, impact evaluation, and process assessment. She researches primarily government programs in India, focusing on service delivery of social intervention. So, Apurva, the floor is yours.
Thank you. Am I audible? Perfect. Okay, thanks. Yeah, thanks a lot to Stefan and the wider team for inviting me on behalf of our larger team to present today on our experience and learnings based on phone surveys to assess mortality in the state of Bihar in India. I want to acknowledge that this is a joint work with a large team of collaborators across universities, as well as our survey partner based in Bihar in India. So let me get started right away. Following on from the previous presentation on mortality in India, as many of you are aware, there are multiple fairly complementary sources of mortality information in India. But there's also a lot of uncertainty about mortality impact despite recent attempts, especially at the state level. And as the previous presentations have pointed out, phone surveys, of course, have emerged as a mode of data collection showing a fair bit of promise for a bunch of reasons. The costs are significantly lower than in-person surveys. Surge in interest during the pandemic. And of course, increases in mobile phone coverage in many developing countries have made it possible to at least attempt to reach a large target population. And of course, their implementation is much easier for continuous surveillance. However, there has been limited use in mortality surveillance. And of course, there are reasons for this. Mortality is a rare event. And of course, large sample sizes can still end up costing quite a bit given lower response rates. So here's a roadmap for my short presentation today. My colleague Ashish is here, and we both look forward to your feedback, and we'll be happy to take questions at the end. So essentially, I'll just quickly talk through a pilot survey that we did that spurred a larger survey that is currently ongoing, and then just some thoughts on phone surveys, their limitations, and potential fixes that we're thinking through. Okay, so let me begin with a quick description of the pilot survey we did in 2021, and then use data to estimate excess mortality due to COVID-19 in this specific state. So this we implemented in June 2021, and honestly, at the time, we were trying to do work as the wave was happening, and we added a couple of questions about mortality to another survey, and I'll talk about how this led to more a larger survey. So Bihar is one of India's poorest and largest states, for the population of more than 12 million. And the main question that we included in the survey in 2021 June was about deaths of any members in the household since April 1st, 2021. So this was super small. We were just figuring out if this can even be done for mortality. So in a sample of about 505 households that we interviewed, we found there were 17 deaths. We calculated person years of exposure based on the household size. And we assumed that dead members died in the middle of the exposure period. At the time, we didn't include dates of death. The mobile phone numbers that we used were scraped from an administrative data set. And in this sense, our work was slightly different from most phone surveys that usually rely on random digit dialing, or like, extensive panels that have been around for a while. So we basically got information from on the beneficiaries of the public distribution system in Bihar. And why we thought this was a good way to go is because 80% of rural households are covered under the PDS, and approximately 60% in our data set had phone numbers listed on this public data set. And our contact rate in this version ended up being fairly high at about 41%. At the time, we did not weight our estimates in the pilot, and I'm going to show you these results. Okay, so the slide here shows annualized crude death rates from different sources in Bihar. So in the blue squares, we see multiple estimates for different years from the sample registration survey, which is an ongoing mortality surveillance project of the government of India. In orange diamonds, we see annualized estimates from the civil registration system. These data for the pandemic period were accessed and released by NDTV, an Indian news channel at the time. The estimates we present here account for the fact that only about half the deaths in Bihar are registered, as was mentioned in the previous presentation as well. So we've assumed for these calculations that the surge in unregistered deaths was the same as it was in registered deaths. In the red circle, we present estimates from our pilot survey. Notice the large standard errors given that it's just a pilot, the small sample size. However, the confidence intervals were still outside the observed crude death rates as observed in the sample registration system. So all in all, we basically observed an annualized crude death rate of 24.3 deaths per 1,000 during the second surge of the pandemic in Bihar. I'm sorry, I think I have echo. Perfect. This observed death rate is more than 4 times baseline mortality that we know for that time. So what I want to point out here is that we found that despite the very, very small sample size, the probability that mortality during the second surge was at least thrice the level of baseline mortality is a whopping 0.88. To us, this experience with phone surveys and subsequent analysis suggested the viability of and need for continuous large-scale mortality surveys. And we wanted to build on this experience of using phone surveys more systematically and raised resources to support a larger effort to collect mortality data in Bihar and hopefully beyond. The survey is ongoing, but I can share our approach in some very, very early summary statistics with you today. So we're currently calling this the Bihar Mortality Assessment Phone Survey, BMAPS. This has been funded by University of Pennsylvania's Institute for the Advanced Study of India. They gave us a grant of like $50,000. And the sampling frame, again, remains the administrative data set of PDS beneficiaries that I mentioned. And here the questions are slightly different. Of course, we are asking for a longer time period. So we have questions on deaths in the household in the last 4 years. And we also ask whether those deaths, if reported, were registered officially. We have questions on the last death in the household if no death is reported in the last 4 years. And this is also partly to ensure data quality so that enumerators don't feel like they can skip one whole section and move on, because either way you are expected to collect mortality data. Piloted multiple ways to measure exposures. We did initially randomize, but we decided to go with a third for all surveys once the protocol was stabilized. So essentially right now we are doing detailed enumeration of household members by age and sex. We also asked respondents to report deaths and stillbirths in the last 4 years. And there are some additional questions of interest on education, healthcare, access, governance implemented in subsamples. So at the time, and this speaks more to also the phone surveys more broadly, we are currently seeing a survey duration, an average survey duration of about 15 minutes. What we are finding right now, we're still only halfway done, is that the observed death rate is approximately 7.95 per thousand in the last 4 years. I should note that we have not calculated accurate person years by year yet, but we do have the information in this survey to do that. Like I said, we've done about 5,000 interviews, 940 deaths in this time. We are worried that the 2020 death rate may be too low, as you can see on the graph, but we're looking into it. And if this pattern holds, we do have a working hypothesis that we'd be happy to talk about in the discussion. Finally, I want to spend a quick minute talking about the limitations of phone surveys and potential fixes. So of course, like one big concern is non-representative samples or just low contact that are due to low contact rates. So of course, our recommendation, and this is something that's come up, is validation as much as possible. And so we ideally want to derive cleaner estimates from a small random sample, so like sort of build a gold standard. And we have some thoughts on how do we go about getting this gold standard sample. One thing we're testing out is if we can invest resources to sample up to 80% of households in a separate gold standard sample. So currently our PDS data has basically 3 types of households, right? So households who are without a phone number, that's about 40%. Households with a phone who are unreachable, that's about 48%. And C, households with a phone who are reachable, that's about 12%. So in some sense, you can imagine we're currently only reaching this C, right? But for the gold standard sample, we aim to reach A, B, and C. So ideally, we can correct for estimates with the fuller sample using this gold sample estimate. Of course, there are still concerns with this that we're trying to iron out. How big should this gold standard sample be? Should this be done in person, or can we just do a more intensive phone survey sample? Those are questions that we are currently thinking about. 2 other concerns, of course, women are harder to reach over the phone, and this is something we know from like the literature on phone surveys more broadly. But we have, at least in our experiences, realized the responses to mortality questions in the household may not vary by gender. We do have a fairly comprehensive mortality roster. And finally, is mortality a sensitive question to deal with over the phone? I know that some people have raised that question, but we think that if you start with broader questions, build familiarity, train enumerators well, our research, at least our experience, shows that this is not really an unsurmountable problem. Hi, sorry, I think there's just, thank you. And yeah, I'll end with this. So finally, we are working towards completing this ongoing BMAP survey by August 2022. And we will have estimates for a bunch of things, mainly the extent to which baseline death rates matched existing estimates from the SRS, overall excess mortality in 2020 and 2021 by age group, social group, and sex, of course, and the extent to which deaths were registered. As I alluded to already, with respect to concerns, we do plan to incorporate weights, concerns about representativeness in our sample, deal with those, and like learn from some other implementation lessons that we've learned. Mainly, of course, we are going to measure mortality in a representative sample and then compare our results, and then compare weighted estimates with unweighted ones. Okay, so with that, I'll end. Thank you, and we look forward to the discussion. And any recommendations on how we can take this forward, this is still ongoing work, will be super helpful. Thanks.
Thank you very much, Apurva, for this great presentation. And so finally, we will hear from Talib Kilic from the World Bank. So Talib is a senior economist at the World Bank Development Data Group and a member of the Living Standards Measurement Study team. His policy-oriented research focuses on poverty, agriculture, and gender, and his research in survey methodology focuses on data integration, measurement error in self-reported data, and the use of sensors for objective measurement. As an expert in complex household survey design, implementation, and analysis, he's also the team leader for the LSMS program on gender and innovation in data. He leads the LSMS Plus initiative on improving the availability and quality of individual disaggregated survey data in IDA country, and he serves as an advisory role for the LSMS Integrated Survey on Agriculture Program activities in Malawi and Uganda. So, Talib, the floor is yours.
Okay, thanks, Stefan, colleague, so much. Can you confirm that you can see my full presentation screen?
Yes, perfect.
Okay, excellent. So thank you all so much. There was a lot of very rich content that was presented this morning, and obviously these short presentations don't do sufficient justice to the very careful and meticulous work that have been done by the presenters and published in various outlets. So I encourage everyone to be actually paying attention to the background documents. So I'm going to be doing my best to provide some overarching comments, mostly looking forward, reflecting on these case studies that were presented this morning, most of which I actually had a chance to delve into a greater detail just over the past few days. So, so I don't have very specific comments on individual presentations. My comments will be, as I mentioned, more overarching and forward-looking, and I try to structure them as to be useful as inputs into a future agenda around the use of basically surveys for excess mortality estimation, including the use of phone surveys, and what this working group may think about investing resources in resolving some of the outstanding issues, I think, from a methodological standpoint, that we ought to be able to resolve to be able to provide substantive guidance for national statistical offices. So in general, looking at this rich body of experiences, I see a need for systematic comparative assessments. And what I mean by that is that clearly these case studies, once we actually go into the details about the survey tools, the fieldwork protocols, there's actually quite a bit of heterogeneity in the survey design decisions that underlie excess mortality estimates. So in view of this heterogeneity, I'm calling for comparative assessments that would essentially help us gauge sensitivity of estimates to key survey design decisions. And I strongly believe that these kinds of comparative assessments conducted in multiple contexts are actually critical for us to be able to formulate substantive guidance and recommendations for national statistical offices to take on board some of these improved approaches to data collection. And then these comparative assessments are in fact done through kind of randomized survey experiments that are planned explicitly and ex ante with a specific objective of gauging the sensitivity of these estimates, rather than working in the pandemic-induced environment that we've been working in, where we all have done our best to cobble together whatever sources of data that we could lay our hands on to give some idea about the sensitivity of our estimate. So we need to be a lot more deliberate. And there's certain key, I think, areas when it comes to survey design decisions that we could actually factor into these comparative assessments. So clearly, one big area is the phone survey sampling frame, and generally the sampling design that have been used for the phone surveys. So there are several studies that have relied on random digit tiling. So for those of us that have worked extensively on phone surveys, even prior to COVID-19 and most certainly during the pandemic, we have concerns regarding the use of RDD in populations with lower rates of cell phone ownership. So I think that is clearly agreed on and have been reflected on in the presentations. And it's not clear that in every context where RDD have been used, the ex-post calibration of these sampling weights to match known population totals in terms of demographic and socioeconomic outcomes, in fact, lead to unbiased excess mortality estimates. So without a gold standard, it is not possible to actually claim unbiasedness, but ex-post calibration is a given in RDD estimation, so that at a minimum has to be done. But I'm just noting this as a concern in context with, again, lower rates of cell phone ownership and hence a significant scope for coverage bias. The second approach that I guess we have seen in various case studies that have been presented today, as well as in other phone surveys, is the reliance on administrative records or cell phone registers, again, from service providers that could be used as sampling frames. Now, this is very context specific, so it's not always possible. Obviously, these administrative systems or cell phone registers may not exist in every country. And in general, their general population coverage is not always assured. So it depends on the database, the purpose of the database, and there may be inherent coverage limitations. A good example would be an administrative database that is designed for a very specific purpose, say for the administration of a social assistance program, or getting registers from service providers for a given country that may not be complete because of not being able to work with every service provider. And lastly, using existing surveys and census as sampling frames is an option. And as part of the comparative assessment, basically various available options to deciding on a phone survey sampling frame could be experimented with. So as part of this option, we have evidence from other phone surveys conducted during COVID-19, including by NSOs, including in our own group, that reveals the potential for this particular approach to counteract significant coverage and non-response biases in context with lower rates of cell phone ownership, and they also lead to higher response rates. We sort of expand on the requirements for NSOs to scale up this kind of approach in the position paper that we put out as part of the Intersecretariat Working Group, and in a separate academic paper that we put out. And these kinds of surveillance systems that I guess leverage existing surveys and censuses could be mobilized in response to both crises and as part of routine monitoring efforts. But this routine monitoring aspirations, we delve into quite a bit of detail in the position paper in particular. It can be realized only through sustained investments in NSO, both the technical capacity and technological infrastructure. And we really need to be systematic about collecting phone numbers in surveys and censuses to be able to leverage this approach to counteract some of the coverage and non-response biases that are typically associated with phone surveys. The second element of basically is the second survey design feature that we've seen variations in is the survey mode. And obviously, for us to be able to provide recommendations on which is the right survey mode to use, again, we need to do a comparative assessment. So obviously, CATI and IVR has been part of the mix, but face-to-face computer-assisted personal interviewing needs to be there, especially now that face-to-face data collection is resuming in many different parts of the world. This has been mentioned. Obviously, mortality is a rare event. So as part of this randomized survey experiment, that would gauge the sensitivity of various estimates to differences in sampling design of the survey mode. Once we do the power calculations, we may actually find that we need quite large sample sizes under each mode to discern differences. But I'm not sure that we can escape from that. And I feel like that may have a specific cost tag associated with it, particularly for face-to-face data collection. But again, for us to be able to provide commanding recommendations, that has to be done at scale for us to be able to show differences by survey mode. But I think the good news here is that to be able to carry out these power calculations, we now have the data, which perhaps we did not have until recently. And that would have also been a concern where we would have been sort of operating in the dark. There are two other survey design features that I think we should keep in mind when we're maybe commissioning these kinds of comparative assessments looking forward. One is the questionnaire design. Obviously, you may have picked up on these details, but the questionnaires that are used in different case studies that were presented to you today, as well as in the pre-COVID-19 household surveys, they reveal differences. A good example of that, a very easy one, would be the reference period. So we do need to do a comparison of these questionnaires, and ultimately, I think, need to converge on alternative questionnaire modules to compare one another as part of this big mix of different permutations of survey design features that would be compared to each other. And finally, I want to say a few words about respondent selection. So, and I saw some comments on this as well. So we may already be sort of speaking the same language with at least some of the participants. But so we all know that on a global scale, women are less likely to own a cell phone. Especially in settings in which in low and middle income countries, both in sub-Saharan Africa as well as in India, which are basically the subject of the studies that were presented today. And now I think a question to us is, in view of these gender gaps in mobile phone ownership, whether the mortality estimates would be sensitive to interviewing a man or a woman. I wanted us, and I didn't look at this in detail, but I wanted us as a group to reflect on the DHS-based evidence, where we actually collect full sibling histories for both men and women, and I did see a comment from Trevor indicating that they're in fact different. So I think I don't want us to brush away this issue about respondent selection. And I think a more careful discussion around that would also need to take place as part of any kind of comparative assessment that we would seek as a community to push for. And finally, I'd like to note two cross-cutting issues, just again, for our reflection moving forward. One is cognitive interviewing. I saw some comments around sensitivity, and these are, these are typical comments that we receive, and they're obviously warranted, and they need to be tackled explicitly about sensitivity of these questions. Cognitive interviewing, in some sense, could get to that as well, but generally about understanding the interpretive process or the response provision on the part of the respondents of these in response to these survey questions that we're asking. It's an important practice. I think and I'm not sure if any of the tools that were presented today were cognitively tested, but in future studies, I think it should be done Stefan referred to an effort which I thought was interesting with the involvement of a clinical psychologist that tried to get at respondent sensitivities to certain questions that were asked in Malawi. I think there are some important lessons learned as well, but that clearly is a very different, maybe very complementary, interesting, but a different approach to say what we would typically commission as a cognitive interviewing exercise. But ultimately, these approaches to understanding sensitivities, issues around interpretation, could be multidisciplinary, and there could be other approaches that we could learn from. But in general, I think we need to be thinking about testing and piloting these questionnaires perhaps a bit more critically. And finally, a word on the gold standard. I think as a community, we should reflect on what the gold standard would be in a comparative assessment. So I think there's several questions here that I would pose for discussion. So, in context with limited vital registration, whether that gold standard would be based on face-to-face CAPI. Would that amount to eliciting a full sibling survival history, or would it be just specific to survival histories of household members? What would be the appropriate reference period? Who would be interviewed? I think these are questions that we need to determine ex ante as part of this comparative assessment, as to formulate the reference point against which all the different alternative ways of collecting data would be compared to. And in contexts where a strong vital registration system actually exists, what would be the conditions that under which this particular system could be deemed as a gold standard? So I did appreciate, Prabhat's slide specifically on specific states where, say, the registration system was deemed to be of providing quality data. I think understanding the conditions and the assessments around that would be critical in commissioning this kind of comparative assessment in a different context where that sort of registration system in theory exists, where we would actually critically evaluate to determine whether or not it could serve as a gold standard purpose. So these are some general comments, most of our discussions and mostly meant to be more forward-looking. But thank you again for allowing me opportunity to provide these comments, and thank you again for all the interesting presentations. Over to you, Stefan.
Thank you, Talib, and thank you very much for these very insightful and thought-provoking comments. I think this is a very useful set of perspectives to have. So I think we still have quite a bit of time for Q&A. So what I would like to do first, I think, is give each presenter a chance to react to Talib's comments in 1 or 2 minutes at most. And then we'll address a couple of questions from the chats that have been posted there. And finally, we'll open up for questions from the audience. Okay. So maybe starting with Prabhat and Yash, do you want to react or add a few things again in 1 or 2 minutes?
Sure. I think the main issue to note here is that use of surveys, phone surveys, for pandemics versus for routine deaths is going to be very different. In a pandemic situation, you have such a high signal to noise ratio that even a small survey, as our colleague on Bihar presented, will yield you an approximately, we think, a correct answer, at least consistent answer with the other estimates. So, I mean, in a routine survey, you'd always be concerned about basing anything on just 17 deaths. But when you observe it in a reasonably pandemic situation, then that seems plausible. So I think we have to bear in mind any of these design issues, noise ratio. In a pandemic situation, even crude calls in an ideally representative sample as possible is useful. The second point I would make is, I think, of course, there's a tension. You want to get representativeness, but the reality is nearly all survey work, short of a complete census, is increasingly non-representative across various countries. So I think emphasizing serial assessments that are done in the same populations where the biases don't change that much in the enrolled populations is a more reasonable strategy than trying to assure 100% representative. So I think those days are very much gone, even in pretty much all survey work. Yash, over to you.
What you already covered actually what I want to say, and besides the fact that this data was not something which we started when the pandemic started. I mean, the process was already in place for almost like 10 years. We have been doing it on a daily basis, and yes, when we started doing CADI in India, it is true that the ownership of mobile was skewed to the upper income, upper education, urban centric. But actually, we started doing that from the 2004 onward, primarily because every year we started getting indication that the data is getting more and more representative, because the ownership of mobile was a great social equalizer as far as India was concerned. Today, probably with the cheapest data rates and cheapest possible hand phones, as I said, that we skip the landline generation. I come from a generation where we used to have one landline in what in Hindi we call in the entire mohalla or entire community, one landline. I come from that generation. Similarly, one TV set in the entire community of maybe say 100 or 200 households. And then all of a sudden, post 1995, and particularly with the data cost going down or call costs going down, and with the calling party pay system, I'm sure that if we would have been having the same model of calling for the charges from the call receiver as is in the US, I'm sure that the mobile telephony would have not taken off the way it has taken right now. And when we do the surveys, similar kind of surveys we do in Bangladesh or Nepal or even in South Africa for that matter, we come across the similar kind of assessment that in the third world countries, in the transitional societies, actually mobile phone telephony has become a great social equalizer. And the have-nots, those who do not have the mobile phone altogether, they remain the same hard to reach population, which you will find really, really hard to access even in face-to-face surveys. We do not find much of a deviation as far as we do for face-to-face surveys, for ISSP, for world value surveys, and many other instruments as well. But we do not find much of a deviation as far as the non-response bias is concerned in the face-to-face or the mobile. Yes, there is a problem in female response, but the female response rate problem is also equally present in the face-to-face surveys in India. It is very difficult for the male researchers in rural countryside to talk to female respondents unless there are male counterparts of their family pretty much present during the interview. What I'm trying to say. And finally, just one thing that there were questions about the female responses. I mean, if picking up the phone, and generally, yes, when you're talking about the perception on something, the female deviation do come in. But when you are collecting the data at the household level, I doubt that these kind of variations come much in place. And particularly at the instance of Prabhat, we did include one question about being very, very specific about people living in that household, and we included unmarried children and death of parents within the same household, even if they were, across somewhere else, because as an Indian household, very much they are considered part of the same household, but with an extended family of sort living or in different household, they are not counted in it. So basically, there was a very, very precise question, follow-up question, when we are talking about the person who have died, was the person living within the same household, how long that they have been living in the same household, or was it that he was visiting and then got stuck in the lockdown and he just died because he was struck in the lockdown, and so on and so forth. So we were very clear in our follow-up survey that we are going to engage only and only about people who were living under the same roof, belonged to the same family, and died under the same roof.
Thank you for these great remarks. And since we are discussing the context of your study, let me quickly ask you the two related questions that were posed in the chat that pertain to your study, Prabhat and mortality that can be attributable to COVID in 2020, 2021, and 2022, as in some instances and during the Delta wave in particular, some excess deaths seem to have been due to other causes besides COVID. So can you briefly talk a little bit more about that?
We know that COVID doesn't kill just through respiratory infection. Now there's evidence that it'll kill through thrombosis, stroke, other efforts. So I think the approach which WHO has endorsed, that in a pandemic situation, excess mortality is perhaps even a better measure than trying to get at COVID mortality is most appropriate. And we see that now when we look at, let's say in Karnataka, where there are some cause-specific disaggregations, that the main excess you see. And so if you think, well, why would heart attack rates go up in certain COVID months, but they weren't in non-COVID months? The answer is they were COVID related. So I think focusing excess mortality for the very specific windows is a reasonably robust approach. There's limitations, of course, with that I'm sure Ariel and others can elaborate on. But it's a robust one. What is our estimate? Well, crudely, if you think that the overall excess during the pandemic months in 2020 was about 10% based on the C-voter data. And then for the pandemic months during 2021 was 108%. So, but remember, the increases are only for those specific time periods, and then they come down to we don't quite know if they're baseline normal. So if you put those together, then that's consistent with roughly 30% overall excess, of which we think the large majority, 27% roughly, was in 2021. And that's consistent with the forthcoming estimates from WHO and with earlier estimates. I do want to emphasize, I think, a general point that's been made, and the Burkina Faso point as well, is the underlying problems we have is a real lack of understanding of adult mortality in so many countries. And I hope one of the lessons learned from COVID will be that all censuses till 2030, I believe, should have a question on, was there a death in the last year, or in the case of pandemics from 2020? If so, the age, sex, and date. We don't have to get cause, but if we had that simple information, in the same way we have children ever born, children ever survived now as standard on census to estimate child mortality, we'd have a huge increase in the quantity and quality of understanding all-cause adult mortality at older ages. And that's a big gap. So I don't know which is right in Burkina Faso, whether the survey is right or the UN is right. But I think getting the censuses systematically to collect this would be a major step forward. And I apologize, I'm going to have to go off to another call. So thank you very much.
Sure. Thank you for your contributions. This was extremely helpful and interesting. So then, moving to the next group, Bruno, I want to give you an opportunity to react or add to your presentation and to the comments that have been made.
Yeah, okay, thank you, Stefan. So I think that The question of adult mortality is really crucial because what is we are also the same result in PRC. We see that there are a lot of differences between UN estimate and what we got in the ramps, and it's something that I think that we have to investigate more. In Burkina, what we are planning to do is just to try to compute some indicators and compare to DHS in order to assess the underestimation or not of adult mortality in the rams. It is something that is going on, but we are not finished yet. It's why I didn't share some result on that review. But I think that with these details, we can have an idea to say that maybe it's likely that adult mortality is underestimated in the rams or not. And the second point that I want also to add is that, for example, in the 2019 census in Burkina, so data were collected on household death during the last 12 months. And for the primary result that we have is a bit higher compared to the RAMS estimate, what we are getting in the census. These results are not adjusted. Just the raw estimate are a bit higher compared to the RAMS. It's why I can say about that on adult mortality estimation. So thank you so much.
Thank you, Bruno. Thank you. And Apova?
Hi. Thanks. I know in the interest of time, I'll keep my response short. But I super appreciate Talib's comments. And these are in line with the concerns that I've mentioned that we're also starting to think about more carefully. And of course, the gold standard construction, as you also said, is a hard one. And I'd be very happy to take this discussion offline and see what we can do already about this as we are doing this piece of work. And also appreciate Professor Jha's comment about making too much from small sample sizes, which is precisely why, what our initial exercise was meant to be a pilot. And the idea now is that we are looking at a 10,000, perhaps higher sample size for just the state of Bihar and trying to make it as representative as possible. So I think more generally, the case we hope this is making is that we need routine monitoring. Phone surveys are easier, cheaper, but of course, I don't think any of us are going to argue that it should come at the cost of the larger, longer-term in-person surveys and systems that many of our countries do have in place, but have seen a setback in the last few years, and not entirely always due to the pandemic. So I'll end with that. Thanks.
Thank you, Apova. Okay, so we are a bit beyond time, but there are still quite a number of people online, and I think we can easily take additional minutes for questions that you guys might have. So I'll open it to the audience. In that case, please raise your hand, and I'll call on you if you want to ask additional questions.
There are two questions actually on the issues of ethics of asking question on the mortality, and also one indirectly related whether if any incentive was given or increased.
Yeah. You're absolutely right. Yeah.
So very briefly, I understand that the issue is very sensitive, but if you are asking with a quite substantial set of questions regarding the general well-being and other issues, and you are moving on to COVID, the impact and everything else, including socio-economic questions, and then followed by deaths in the family, in discussion, people do talk, and they do talk heavily. We do not offer any incentive, first of all. India being a contextual society, people love to talk and tell the story, and particularly during the pandemic times when the lockdowns were there, people were just stuck in home. So probably they were giving more time as well in that way. Having said that, I understand that the huge problem of low response rate in CADI in the West might not apply as much in the developing societies. That is the one thing. Second thing is more on particular work that we do, because our majority of the work actually is done for the media and appears in the media. People are pretty much aware of the work which we do. So we might be beneficiary of that people like to talk when we say we are calling from seawater. It's more of a brand awareness probably. So basically our experience might not be applicable on others in that way. But in general, I don't see having much of a problem in asking these questions to people. I mean, even in the worst of their times, they do tell what are the problems that they are sharing, because there is an inherent thing in their mind that if they share their problem and that gets reported in the media or something in the volume medium, there could be a solution coming to it. And we say this upfront right in the starting in our introduction, that there are not going to be any incentive whatsoever. And second thing, that our work is going to appear in the public domain. So that's how the response rate is really high. We get 50% plus response rate actually. That's quite substantially high when you compare to 2 or 3% or maybe at best 5% in US right now. And that pretty much is applicable in Bangladesh, in Nepal, in South Africa, and majority of the developing societies that we have worked with CATI on, the response rate has been fabulous. We never faced any problem on the response rate.
Thank you, Yash. And I think that's also a statement that extends from what we've seen to the study in Burkina Faso and to other parts of the RAMS project, so where response rates were high as well. So that's particularly encouraging for this type of inquiry. Absolutely. Any questions from the audience? I don't see anything else. I think we have thoroughly tackled the chat.
Stefan, if I may just make one last
yeah, of course.
And something I forgot as I was presenting. And one thing we often forget about, and partly because many of us are, at least in the pre-pandemic world, we're doing in-person service a lot more, is just fatigue. And I think fatigue sets in way faster on the phone, because there's unless you're repeatedly being surveyed by the same people, there's no relationship, they can't see you, they don't know who you are. And this isn't really just about trust, it really is. I mean, any of us will perhaps at best give 15 to 20 minutes to a phone survey. And so I just feel like if we are also thinking of ways of adding these questions to existing modules, I feel like we should be careful about the feasibility of doing that without sacrificing serious quality of the kind of data we get. So that would be my one sort of point that I think is just important to consider as we design these further.
Absolutely, Apurva. And I was about to say that in your very first slide, it was bang on target. For us, the upper limit is 15 minutes, not 1501. 15 is the upper limit. We just do not, we refuse to do the work for any client who asks us to do 16 minutes. So we say, chop it down the questionnaire, no more than 15 minutes. That's the upper limit. Because if I cannot talk to anyone more than 15 minutes, my respondent cannot talk. So that idea of doing 40-minute survey that's unrealistic, absolutely bookish in nature, and it's impractical.
So I'll take my prerogative as a chair here to react a little bit to this, because I think throughout the pandemic and even before, there have been surveys that have gone well above that 15 minutes on the phone, and you know, that have produced results. And I'll cite to one thing we're doing as part of the RAMPS project in Malawi, is we're having a randomized trial with randomly selected phone users, where we assign some of them to 10, 20, or 40 minutes interviews, and we place the same set of mortality questions at the end of each interview to see, you know, just how much worse things might get after all that time. So I'm hoping we might move a little bit the upper threshold you're giving us in that regard, but I think, you know, that might give us some sense of where unbearable fatigue really sets in. So I wanted to mention that. So if we don't have any more questions, I think we need to wrap up. What I do want to do first and foremost is to thank every one of the presenter and Talib, our discussant, because this was really a wonderful set of presentations. I know I learned a lot about this set of activities, about excess mortality and the challenges in measurement. So that was extremely helpful. Thank you again, Talib, for the very thoughtful comments and for essentially mapping out the research agenda that should continue this amount of work. And I wanted to thank all the people in the audience, the working group members, and others who joined us today. It was great to see this many people connecting to the webinar. So I'll also do a little bit of advertising here. So this webinar is the first in a series of 3 that this working group is organizing on various issues in censuses and surveys as they pertain to mortality measurement in the context of pandemics. We'll have another one next month and another one in June. The likely themes have to do with sampling, and so issues of sample size and statistical power in surveys, as has been pointed out, is a major issue. So how do we think of survey design in trying to estimate excess mortality in that case? And probably in June another session on causes of death and the measurement of causes of death in surveys. What can we and can we not do in a realistic manner? And all of this is leading to our work on the development of a set of recommendations and guidelines, so to speak, that we would like to formulate for national statistical offices and for use in either routine operations or future epidemics and pandemics. This will also manifest in the organization of an expert group meeting at the end of the summer in Abu Dhabi, where a lot of this will be discussed much more extensively, and draft set of recommendations will be discussed and formulated. Okay. So that's where we are. Thank you, everyone, and we'll I guess we'll close this unless there's something else that I've missed. Cody and others.
Thank you, Stefan. Nice to meet you all.
Thank you. Bye-bye.
Thank you.
Thank
Thanks
you.
for your comment.
Thank you, everyone.